Hey everyone, welcome to our October Ambassador Briefing. And for today's briefing, we will be talking about the immunosuppressive drug coverage that's going to be extended beginning in January. And we'll also talk about upcoming elections and what it means for advocacy. And then once we're done with those two topics, then that is when we will do the open-ended question and answer time at the end, where folks can ask any questions they might have. So without further ado, I will turn this over to my colleague, Mike.
It's Ben. Can you hear me okay?
Yeah, I can hear you.
Okay, great. I have new headphones, so I just want to make sure. Ben, I'm going to share my screen.
You're a co-host, so you should be able to.
Okay. Okay.
Sorry, Mike, I muted everyone. Okay, there you go. Unmuted now.
Sorry about that. I'll start again. So a lot of the information here on these slides I presented back in June during the that month's ambassador call, but there is some new info that I wanted to start off with. So this is the new info that I thought people would like to see right up front, and I'll repeat it at the end after I run through what the new immunosuppressive drug coverage in Medicare is and who is eligible. So if after I go through what the program, what the new benefit is, if you think you are eligible and want to pursue signing up, how you would do that is you call Social Security at the number that you see on your screen. It's 1-877-465-0355. And this is a special phone number directly dealing with the new immunosuppressive drug benefit. And if you are a TTY user, you would call the general line at the number on your screen there, 1-800-325-0778. The monthly premium for the new drug benefit is $97.10 for 2023. That's the minimum premium. I assume most people, that's what they will pay. If you make $97,000 or less in your yearly income as an individual tax filer, or $194,000 a year in 2021 as a joint filer, then that's what your premium would be, $97.10. If you make more than that, then the premium goes up based on where you are in the income range. There is also a deductible for the benefit. It's $226 for 2023. And then once you've met the deductible, you'll pay 20% coinsurance based on the Medicare approved amount for your immunosuppressive drugs. For lower income individuals, you may be able to get help paying for this benefit from programs that are offered through your state. And you can contact your state's Medicaid office to learn more. There's a link here. If you go to medicaid.gov, you can find the contact information for your state's Medicaid office. I also want to point folks to another resource that can help you navigate your options for Medicare coverage. It's called the State Health Insurance Assistance Program, and through or SHIP, and there are local SHIP offices throughout the country, and you can find your local SHIP office at shiphelp.org or call 1-877-839-2675. It's a great resource. They give objective information It's funded by the federal government, and it's a good resource to help you navigate your Medicare options. And then all the information on this slide can be found on medicare.gov at the URL at the bottom of the screen here. So just to backtrack on the immunosuppressive drug coverage. So what is it? So back in December 2020, there was a law passed that created the new benefit. And the shorthand that I'll use is called the Part B ID benefit, and it becomes effective January 1, 2023. So for people, I'm sure most people on this call know that for people in Medicare, because of ESRD and who do not otherwise qualify for Medicare, that means they're under 65 or they're not disabled, then their Medicare coverage ends 36 months after they receive a kidney transplant. With this new Part B ID benefit, there's now a new coverage option for those kidney transplant recipients who can't get other health coverage after their 36 months of Medicare coverage ends post-transplant. The new benefit, it only covers immunosuppressive drugs that are needed to prevent organ rejection. It's not comprehensive health insurance coverage. So it doesn't cover things like hospital care or doctor visits or labs or tests or prescription or other prescription drugs. So who's eligible? To be eligible for the Part B ID benefit, an individual has to have received a kidney transplant in a Medicare certified facility. They had to have been eligible and applied for Medicare prior to their kidney transplant, even if they did not enroll. And then they do not have other health insurance coverage. That includes Medicaid, qualified health plans on the ACA marketplace, health plans for your employer, TRICARE, or VA benefits. So how do you enroll? You call that number I said at the beginning. That's the Social Security Administration. And you have to provide a verbal attestation that you are not enrolled and do not expect to enroll in other health coverage. Alternatively, you can also submit a written attestation to Social Security with a pen and ink signature, but honestly, I wouldn't do that to start. I would just call the number and talk to a person. And then after that, the Centers for Medicare and Medicaid Services, CMS, and Social Security will confirm your eligibility for the Part B ID benefit based on the information that they already have regarding your Medicare entitlement at the time of your transplant. And that's it. Your attestation and then their confirmation based on their info that they have on you on file is all you need to enroll. If Social Security denies your enrollment, you can have an initial determination entitlement appeal. When can I enroll? So if your 36-month post-transplant Medicare coverage ended prior to January 1, 2023, you can enroll starting now. It started October 1st or later. If your 36-month post-transplant Medicare coverage ends on or after January 1, 2023, you can enroll at any time when your coverage ends. And then when does the coverage start? So if your 36-month post-transplant Medicare coverage ends on or after January 1, 2023, and you submit the required attestation before your coverage ends, your immunosuppressive drug coverage would begin with the month your 36-month post-transplant Medicare coverage ends. If your 36-month post-transplant Medicare coverage ends on or after January 1, 2023, and you don't submit the required attestation before that coverage ends, but you provide it later, then your Part B ID coverage would begin with the month following the month in which you provided the attestation. So there'd be kind of like a 30-day gap. And then if your 36-month post-transplant Medicare coverage ended prior to January 1, 2023, and you submit your attestation as part of the enrollment process from October 1 of this year through the end of this year, December 31st, then your Part B ID coverage would begin January 1, 2023. Other things to know, if you are enrolled in the Part B ID coverage and then you enroll in other health coverage, like comprehensive coverage, then you wouldn't be no longer eligible for the Part B ID benefit. and you have to notify Social Security within 60 days of enrolling in that other coverage so that you can terminate your Part B ID coverage. And then if you terminate your Part B ID coverage because you enroll in other health coverage, but then you lose that coverage later, you can re-enroll in the Part B ID benefit at any time, as long as you meet the eligibility requirements and submit the attestation. There's no late enrollment penalties assessed, regardless of when you enroll, re-enroll, or disenroll from the benefit. CMS plans to include information on the Part B ID benefit and enrollment instructions in the pre-termination notice that is sent to beneficiaries as they approach the end of their 36-month post-transplant Medicare coverage. So this slide's just, again, reiterating what I said up front. If based on this information that I just presented, you think you are eligible for this new immunosuppressive drug coverage through Medicare, then you would call Social Security at this special number they've set up, 1-877-465-0355. And then again, this is the information for further resources that may be helpful. So, and then that is it. I am happy to take any questions that anyone has.
So Mike, I know this is a question we got in an email, but I want to just present it to everybody here in the briefing. But if you were on Medicare and had a transplant, but your 3-year coverage already lapsed, are you able to get the coverage back?
The new immunosuppressive drug coverage?
Yeah.
Yeah. If it's already ended, you can enroll now. And if you do it for the end of this year, then that coverage, that immunosuppressive drug coverage can begin January 1, 2023.
Mike, is there, I mean, can you do this online, or can you fill up a form and mail it to them to see if you qualify? Or, because, you know, I'm sure that, you know, if you contact them on the phone, I've been on the phone for them on hold for an hour or 2 hours, you know, to avoid that, is there another other way we could do that?
From what I have seen, it seems like they want people to call and do this verbal attestation. I think CMS thinks that's the most kind of like streamlined and, you know, kind of direct way to do it, especially with this new benefit.
I found a different predicament because 11 years I had a kidney transplant and I exhausted to 36. I was on Medicare, and then I found a job, and then the job had the insurance, and then I withdrew from the job, and then I came back, and now I have a liver transplant. And so I try to reapply. They say I owe a balance, but I'm going to see, so I need to apply again this year in order for me to qualify for January 2023, right?
What coverage do you have right now?
Right now I have my employer. Actually,
okay.
It's what do they call it? It's Community First, and it's Cobra, and I'm paying $340 a month right now. And I receive my disability. I only have Part A and Part D, but you know, they said I need to reapply, but they say that I didn't qualify because I owed a balance. That's when I was working. And so I told them I just received a liver transplant. I said, I need to reapply again, but I don't want to lose that immunosuppressant now that I have a dual transplant.
So yeah, so it is complicated because of the liver transplant. So just based on the fact that you have other health insurance right now through your employer, you wouldn't be eligible for this right now.
Cobra's temporary because that's what they offer you. I resigned July 31st, but that was the only option that they have because I didn't have other insurance. So that's expensive. Honestly, it is expensive for my budget right now. But I'm now, if I do this, all this again together, now it takes a year to recover. I'm trying to find another job, and I'm confident that I will. But I'm reapplying again, and then if I find a job, then I'm going to find myself again from the very beginning.
I think when does your Cobra coverage end?
I think it ends next year. I think they give you 6 months after or something like that. I think I believe it will be this year. I
think you could contact Social Security as you approach that end date of your Cobra coverage to see if you are eligible for the immunosuppressive drug coverage. And
I believe it's month to month.
There's not a gap.
It's month to month because I'm paying them by month. There's no contract or anything like that. They just say, okay, this is going to be for now. So it's not a contract that I signed or anything like that.
Yeah.
I'm sorry I just want
no.
It's complicated for me, but I want to see maybe you might have a direction.
Yeah, no. Yeah, I mean, you can always, call Social Security, and they could probably help walk you through your eligibility and the process there. But yeah, no, it's complicated. Health insurance is complicated. We have a very complicated system.
Would it be a lot easier if you visit the location, the Social Security location would be instead of calling? You think it'll make sense to, even though it's a 2-hour wait, but.
Yeah, I mean, I think that would be, that's definitely an option.
Okay.
I have a question.
Thanks, Mike.
Sure. Yeah.
I have a question, and this is sort of in line with what Mike was saying. Is there an advocate at Social Security or something? Because he runs the risk of losing his COBRA coverage to leap to something that's uncertain that they may deny, and it's nobody at Social Security that really seems to understand, what's really going on in terms of this extended coverage.
Well, the fact that they have set up this special number to deal with this new benefit, I think that might be the best way, the best avenue to talk to someone who knows about the new benefit. That's my guess, but I can't really speak on how people's experience will be as they talk to folks at Social Security.
Because Mike, this also applies for people that are pursuing a second transplant, right? They go back on dialysis, right? And so if they're already exhausted 36 months after they receive their second transplant, right? So it kind of applies to the same thing. What is it they're going to do if they're already exhausted for 36 months?
Yeah, so you can re-enroll in this immunosuppressive drug coverage if you don't have other coverage. So yeah, so a person who's on their second transplant and then their 36-month post-transplant coverage ends, they may be eligible for this if they don't have other coverage. There's no limit to how many times you can enroll in this coverage based on your situation as the rules are written.
So, Mike, there's a bunch of questions in the chat. I don't know if you saw those or not.
I have not.
Bobby, if it does 15 months, it's still really expensive. I mean, I'm paying $340, so I'm looking for something cheaper.
Yeah, I mean, and the caveat is that this coverage only covers your immunosuppressive drug coverage. It's not comprehensive health insurance. So just keep that in mind. Yeah. It is an important lifeline to continue access to these obviously important immunosuppressive drugs, so your transplant you can keep your transplant.
On that COBRA coverage too, just so you know, Dave, they're legally permitted to tack a surcharge onto there from your employer plan of I think it's 20% more that you pay than what the employee plan is for service charge or something. And by the way, whenever the plan renews with that employer, at the beginning of the year, they can go back in and reevaluate it and charge you even more money, on there. So it's offered as a stopgap measure. It's very expensive to have it, but at least it gives you the same type of coverage that you had while being employed. And it is comprehensive.
And it is because I received $1,700 of disability, and of course I pay my rent, I pay everything, and it takes a huge chunk of that. And so that's what I'm in the red every month. And so I'm so grateful for my family, but still, this is something that I think for people that are independent like myself, there's limit of resources. If I was a single parent, boom, I would have everything, but when it comes to independent people, they don't have those reasons. And that's one of the things that I'm very vocal about it, is that independent, they told me at food stamps that I received too much disability. That's why I don't qualify for food stamps. And if I did, it would give me $15 or something like that. and it's not worth it because that's the gas to get there anyways. But
they
yeah,
just changed the bare minimum, the entry level limit on the food stamps too. So they just raised it recently within the past month. So you may want to reapply or check on that.
No, they shut me down. This is just recent. They shut me down completely. Really? Yeah, they said that they can't because, you know, and they like I said, they had the audacity to say if I was a single parent, then I would qualify for $300-400. But I don't. I'm independent.
You know, another resource that you might want to tap is go to your state legislator, you know, within the state, and ask them. They have like a health person on that they hire on their staff who would be able to steer you to potential resources. Most of those offices keep lists. And they can say, well, did you try this? And then this is your next option. Like they work for the state legislators doing that, and they compile a list of like resources. I was recently at a Chamber of Commerce meeting where they had nonprofits there, and they had the state representatives there as well as the local nonprofits, and they told us about that list that's available. So you may want to double check that.
Yeah, we actually made contact. Ben and I did in Texas with state legislator chief of staff. I forgot his name, but Ben and I did speak with him a few months. Maybe I could reach out to him.
But specific to your issues regarding the insurance coverage and stuff like that, not necessarily kidney issues in general, but your specific issues, they may be able to help you navigate this mess.
But you know, Bobby, I'm eager. I mean, I'm already going to complete a year recovery, and so I'm eager to go back in the job market. But still, if I do, like you say, Mike, if I do go back, you know, I'm confident that I will find, you know, that's the whole purpose of getting a transplant, to get your life back, right? And so I'm being brought back because of it. But if I do get a job with insurance, then I don't know how that's going to work. If I'm going to miss out on the immunosuppressants medication if something happens, you know, things like that. So that's different ways how one
of the programs that they have too within the state of Pennsylvania, it's called a back to work program, whereby you can go back to work and make a salary and still be covered under their benefit plans. Here again, that's, you know, part of the state.
As a secondary or
it's like you can, when you make up to it, you can make up to a certain limit and they'll still continue to provide you like with the insurance coverage or like Medicaid or whatever it is. But there are known back to work programs that exist. That's why I'm saying that your representative might be a great resource there to find out, you know, if you want to go back to work, is there a back to work program that I could still keep my coverage without having to pay this exorbitant COBRA fee, you know, that kind of thing to get the coverage.
Because I'm certain I'm not the only person that's going through this, you know, even for those people that get another transplant.
You're not.
Yeah.
And it's just, it is absolutely ridiculous. And I put this thing in the chat, and I'm sorry, but I feel very strongly about this in terms of people trying to navigate the system. And I really wish that they would have some type of an experience journey for those individuals, you know, even a 1 or a 2 day workshop to just show just how hard it is to navigate through their own system, especially when you are not feeling your best and you're trying to get some assistance. There is a market for paid advocates, but nobody should have to pay an advocate or an attorney to have to sue to get the benefits that they are authorized by law to get. That's just my opinion.
I mean, they do give workshops for applying for food stamps. Automatically, they give workshops to make you sign to go to the Employment Commission in order for you to, if you don't sign for the Employment Commission, guess what? You don't get food stamps.
That SHIP program that Ben mentioned, that he mentioned earlier, that he was talking about in the conversation, it's called different things in different states. In Pennsylvania, it's called PA Medi, but you do go to the main SHIP website, and they have insurance counselors and attorneys there available free of charge for people who are trying to navigate the Medicare system. And they go according to your zip code as to what office of the SHIP program that you would go to. You have to call them up and make an appointment.
So this is a pro bono firm, or?
No, it's not. The SHIP program operates out of the Area Office of Aging, within the federal government, and there's money sanctioned or set aside for each individual state to provide these services to individuals relative to insurance benefits and Medicare. And that he did talk about that on one of the slides there, and I don't know if he gave the number for it or not, but do a Google search for SHIP, SHIP, and look up your state. and find out what it's called and get the closest local phone number depending upon where you live. Call them up and make an appointment and tell them your situation, and then they will do everything free of charge to say these are your options as well. And that might even be one of the resources that the state representative office would give you, but it's available there. We have used it extensively with my son.
Yeah, the last thing you want to do is people give you the runaround and, you know, to go here, go there, you know what I mean? And instead of going to the source.
Yeah, they would tell you, like, do this. Like when we had trouble getting onto Social Security initially, whenever my son was first diagnosed with kidney disease and kidney failure, the SHIP person, even though he's not allowed to say that he did this, but he knew people in Social Security. And all of a sudden he said, okay, well, we'll look into this or we'll come up with some ideas. And the next thing you know, the Social Security person's calling me because he made a phone call and cut through the red tape. You know what I mean? Like they know the ropes on that. So I think that they might be of an extreme benefit to you.
Thanks, Bobby, for sharing that information about SHIP. Yeah, that's really helpful. And yeah, I did provide, it's shiphelp.org is the website to find your local SHIP office. And I did also provide the number. It's 877-839-2675. That's the SHIP number that you can call to find your local office.
Can you repeat that number?
877-839-2675.
Thank you.
Yep. There was a question in the chat earlier from Kyle. Do we know if CMS will assess premiums quarterly, if not on SSI or SSDI, auto monthly debits similar to premium handling on Part B currently for dialysis patients? I don't know the answer to that off the top of my head, but I can look into it for you. And I think that was the only question in the chat.
Keep in mind too, on that SHIP program, different states call it different things. Like in Florida, it's called SHINE, S-H-I-N-E. In Pennsylvania, it used to be called a prize, but just within this past year, they changed it to P-A-M-E-D-I, P-A-MEDI. In some other states, they do technically or truly called SHIP, but it's called different things. So don't be alarmed if you're seeing something different other than the word SHIP when you look up the information or make a phone call on that.
Well, my guess is that if you contact them, they probably should know the you know, for other states too, they might have their contact as well, right?
I think it's right on their website. You can actually look and it'll say what state are you in and this is what it's called and this is your main state number. That might be the quick way to circumvent an 800 number that's not really geared to where you live down here in Texas. You know what I mean?
Yes,
yeah. Shiphelp.org. I think they have like a function right at the top where you can type in your location and then they'll direct you.
No further questions. I'll thank Mike for joining us again to present. And luckily we had the star of the show leading off, and I will take over here and talk about the upcoming elections and what it means for advocacy. So there is a lot of uncertainty of what is going to happen with the elections. A couple weeks ago, it looked like the Democrats were going to hold on to the House and the Senate. Currently, according to polls and projections, that is much less likely to happen. And we are, I guess, 12 days away from Election Day in Maryland, or at least in Montgomery County, where I live. Early voting started yesterday, so people have already begun to vote, but it'll take a little bit to find out exactly what the results will be. But how that affects advocacy is if the Democrats lose either the House or the Senate, then the way it works is then the Republicans will choose the leadership positions and who will be the committee chairs, the vice chairs, the subcommittee chairs. And in a perfect world, the people who would have those positions will be chosen based on expertise. But usually committee posts are chosen either by seniority, or a lot of times you can jump seniority if you can raise a lot of money and help other people in your party. So unfortunately, I know like the science committee is not considered one of the top ones. So if you're new and you are not a good fundraiser, that is where you will be ending up. But what that means for us in health, the health related committees and commerce committees, things like that, those are all pretty high profile committees. So if there is a change, there will definitely be a lot of jostling for leadership there. So we will have to sort of just wait and see how it all shakes out.
I think more likely the Republicans take the House. The only thing that's up is the Senate. There's 4 seats, and with debates in Pennsylvania, I'm sure that they're going to gain 1. And so the other 3, not sure. So once we get I guess Republicans get 2 in the Senate, 2 more in the Senate, I think they're going to take over the Senate.
Yeah, I mean,
it's predicted.
There's still a lot of time between now and Election Day. Yeah. But so what I was going to say also is that if the Democrats lose the House, which is looking very likely now, then Nancy Pelosi will no longer be Speaker of the House. And then if she's not Speaker of the House, the assumption is that she will not be in leadership anymore. So if she's not in leadership, everything sort of trickles down from there. Then whoever will take over will be minority leader, and then they will have the authority to choose all the new committee chairs. I forget which committee it was, but Carolyn Maloney from New York, she lost her primary to Jerry Nadler, who Jerry Nadler is a great support of ours. So happy to see him win. But because of redistricting for her and for lots of other people, there's already been a lot of turnover, with the usual retirements and all that. So there's going to be a lot of new members. So as soon as the election results are done, in my department, we're going to be compiling a list of who the new members are, if we've had any connections with them. If somebody goes from the House to the Senate and we already have a relationship with them, we'll still reach out and everything, but it's a much easier lift. I'm sure as you all know, a lot of elected officials, if they don't have any personal experience with kidney disease, have absolutely no idea about anything relating to it, which it's an opportunity for us, because when you get in, you want to learn, you want to serve the people that elected you. So a lot of people are willing to listen to us. So we'll be doing specific outreach to people who got brand new members, ambassadors who got brand new members, and ambassadors who were shifted into different districts. And once again, if presumably Democrats lose the House, Pelosi steps down, the current thinking is that Hakeem Jeffries from Brooklyn would probably take over as minority leader for the Democrats, which would be good for us. We've done a lot of outreach with his office over the years. One complication with that, though, is that he would be the top Democrat in the House. He's from Brooklyn. The current top senator in the Senate is Chuck Schumer from Manhattan. So presumably the leader of the Senate and the leader of the House for the Democrats will not be from the same city. So I don't know if that means Chuck Schumer steps down as well. Even if the Democrats win, there's a chance that he steps down also.
Ben?
Yep.
Question: when does all this take place? Immediately after the election, or will it all kind of take place at the beginning of the next year?
Oh, so good question. So unofficially, it takes place pretty soon after, for who's going to be speaker. Like if, let's say hypothetically Pelosi is going to step down, Hakeem Jeffries probably already has his list of votes that he would get for who would vote him for either minority leader or speaker, because Pelosi might step down even if the Democrats keep the House. So I'm sure his team already knows how many votes he has and who else he has to reach out to. You know, I believe the current number 2 is Catherine Clark from outside Boston. I think Harvard is in her congressional district, so maybe Cambridge, Massachusetts. She's number 2. I know Jamila Prayapal from Seattle, or at least Seattle area. She's the chair of the Progressive Caucus. She has either quietly or very openly been looking to rise in leadership. So she might try to give it a go to be minority leader, because it also gives you the geographic diversity as well. And I'm not sure who else is on the short lists for if the Republicans take over. Granted, you know, everything has to shake out, but if the Republicans take over the House, it is not expected to be for the Republicans to have much turnover in their leadership, if at all. They would sort of just elevate the people who were serving in the minority leadership posts. Mm-hmm. But read an article a little while ago that said there would be a big shakeup if Republicans take the Senate. What that looks like is anybody's guess, but regardless, after Election Day, there's going to be a lot of new members of Congress. Most likely a lot of turnover in leadership regardless of the election results. So there will be a lot of work for the ambassadors, such as all of yourselves, to do. So like I said, we'll be reaching out to everybody and letting you all know sort of the status of your members, what are the options for advocacy. Because one thing that kind of sucks when you have brand new members is it takes them a long time to actually staff up their staff. So when the new members in the House or the Senate, they come to DC, a lot of times they bring their campaign staff with them, because if you were not involved in federal politics at all, you know, those are the people who got you to where you are, so you feel loyal to them. Mm-hmm. But I mentioned this before, working on Capitol Hill is not viewed as the greatest job for the people who work on Capitol Hill. There's super long hours. DC is a very expensive city, so I'm not even sure what the pay rates are now, but it's not enough for DC. And you get screamed at by people all day long. So there tends to be a lot of turnover for the staff of new members sort of within that first year. You know, you have to be sort of a special breed to be a Capitol Hill person. And a lot of folks who come in from the campaigns, that's not what they want to do. Campaign people are a specific set of people, and Capitol Hill folks are a specific set of people as well. And so it takes them a while to staff up. A lot of times what happens is when you get new members that come in, the parties will have people that they recommend that you hire, or they'll have people who have worked for the party organizations that could help ease the transition for a new member. So you hire those people, or you can hire staff from other offices, and either it's a lateral move or you can, you know, give them promotions. So it just takes a little bit of time to staff up. And then, you know, who might be doing the healthcare legislation in January, February is not necessarily the person who's going to be doing it in June. You might just be dumping it off on whoever you have for staff at the moment. And then that could change a lot. So we're definitely going to be aggressive in reaching out to the offices and making those connections. But we're not going to do it, you know, what new Congress is probably middle of January is when they'll get sworn in. So we're not going to do it like right away. You know, we'll send materials. In the past, we've always sent sort of new member folders to be distributed to the members' offices, so they can at least have some information from us. But we will be certainly be emailing them a lot of material as well. And then as for committee structure, as I was talking earlier, a lot of the committee posts will change because there will be a lot of turnover. And so, like I said, the science committee is usually where people get dumped when they're not going to be have any good fundraising skills. But there is, the leadership does try to have geographic diversity within the committees, unless it's like agriculture tends to not have a lot of Northeastern congressional members in the committee. That tends to be a lot of sort of the middle America states and California as well. So they do try to find some connection. Also, some members, if they've been on committees for several years and they feel like maybe they're not getting their legislation through, or they just feel kind of stuck, then members will ask to be switched to different committees. So there will be a lot of shakeup on the committee. So we'll be waiting anxiously to see who will be on all of our related committees, and we will eagerly be reaching out to them so they're aware of us and our positions and are looking to work with us. And if I had to guess, I'd say a lot of the folks who will remain on our relative committees will be folks who've been there before. So I don't want to scare anybody and make everyone think that all the work we've done over the past years is going to go away. And it's going to be everybody we've worked with is just going to be replaced by brand new members. But in a new Congress, especially after redistricting, there is a lot of work to do. And for vast majority of you in this Zoom, I have your number saved in my cell phone. So when the opportunity arises, you will 100% be hearing from me. But want to see if anyone has any questions about redistricting advocacy for next year. So I can say, I've been doing a lot of the in-district meetings, and offices are starting to talk about doing in-person healthcare events, senior events, veterans events. And, we've emailed all the offices, and in the meetings, we let them know that we want to have a presence. If it's us having our materials on a table or possibly attending the fairs as well, we're more than happy to do that. But we are based in Rockville, Maryland. We're not, even though we are a national organization, we only have one office. So we might be relying on some of you to attend some of these meetings. And also, most importantly, I always say this, and we always ask folks to get on social media for your members of Congress and get on their distribution list, their email lists, so you all can let us know when events are happening, because we don't always find out in time. And it would be great opportunities for some of you to participate in those fairs as well. I know Bobby has participated in lots of these different fairs over the years. But Bobby has also let us know about both state level and federal level health events that we've sent packages of materials to the members to be distributed. And
I have a question for you, Ben. I think it's pretty obvious now that nothing's going to happen with the LPDA at the federal level.
Well, no, I wouldn't say that.
mean, well, because we're nearing the end. Election is in like another week or so, and people?
So LDPA is not going to pass on its own, but we keep on getting more and more co-sponsors. So there is a chance that it could be folded into other legislation. So we do think there is a chance that LDPA could pass at the end of the year, but certainly it's not going to pass on its own.
Okay, so it still might go, but if it doesn't, then when you mentioned earlier about starting all over again, is that basically it has to be reintroduced and we all have to start all over again?
So yes, it has to be reintroduced, and you do have to get the members have to sign on to it again. Mm-hmm. But that's not as big of a lift, because we just come back to the offices and we say, it's the same legislation as last time. your boss was a co-sponsor last time, will your boss do it again? And 99 times out of 100, they do, because members, in general, members don't want to support legislation that they don't think really has a chance of going. So if, you know, we have legislation that keeps on building steam, you know, it's definitely something that people do want to sign back onto. Yeah, Kyle, LDPA is Living Donor Protection Act. Yeah, so with it getting more and more co-sponsors every time or every year, it is something that people would definitely be interested in supporting. And LDPA has a lot of bipartisan support. And you know, people in different parties look at the legislation differently, but there is a lot of support for it.
Unfortunately, I'm in one of those districts where we are getting a new senator and we're getting a new congressman. So, you know, we know it's not going to be the same person and everything because of one was redistricting and the other one is, well, in Pennsylvania. That tells you what's going on. So, you know.
Well, he's a doctor though, right? So he might have.
He is a doctor. He's a heart doctor, but you know, I think he would be probably receptive to medical issues or be familiar with it. So that's that. I think that's the one blessed thing in our favor, you know, with that.
But a little advantage there.
A little bit, yeah. Yeah, I think so.
But yeah. I mean, we just have to wait and see. And really, what's key is who their staff members are, because the members themselves don't really know that much about the legislation. For a lot of things that are sort of right down the middle, real matter-of-fact legislation, they rely very heavily on their staff to advise them on what to do with the legislation. And so with the staff members that, you know, we've been working with over the years, it's a much easier ask to get them to ask their boss to support the legislation again.
And if it's a new staff member or new person, then you just have to re-educate them to get on your side of the thing. You break them in, I guess.
Yeah, but I mean, we've done plenty of meetings where the person is new. They don't know kidney stuff really, but they see that their boss has signed on before. And as long as it is the same legislation, then it's fine. What can happen a lot of the times is a bill, for whatever reason, doesn't make it through either, you know, subcommittee or committee, whatever. And then people make changes to it in the following Congress. So in an effort to get the right people to support the legislation, but that can have negative effects when we try to get people to support it again. So any other questions about next year advocacy?
Whatever happened to the executive order that Donald Trump signed? Remember, he had a lot of, and then after the new administration came in and it went quiet. Do you know anything about that?
Well, so what happened with the executive order is they wanted to really promote at-home dialysis. And so, correct me if I'm wrong, but what it did is it provided
more funding,
money.
Right?
It was funding for educating folks about at-home dialysis,
Kidney X and all them.
Yeah, and so from my understanding, none of that went away.
Okay.
It was a non-controversial thing. It's just
it was supported by the Republicans, so I mean,
yeah. Well, it's, you know, it's just nature of the beast in DC that you have stuff like that a different administration put a lot of fanfare into it, but in the grand scheme of things, it's not controversial at all. So it still continues, but it's just not a priority. And really, it wasn't, even though Melania Trump had the whatever her kidney issue was, it wasn't really pushed by President Trump. It was pushed by Alex Azar, who was the Secretary of HHS. And so him leaving is what made it sort of less of a priority. I'd say, well, let me rephrase: him leaving and COVID, because COVID sort of took over everything related to health, from the congressional offices to HHS. So, it's still there. And we fight for more funding for everything kidney related, but I would just have to say it's probably not as much of a priority as it was previously.
It wasn't stricken down though by the Biden administration,
No.
was it? It's still like it's in the radar, but it's not like in the front of the thing because it's not like a big high priority on his end. And
yeah, that's why he went quiet. So after he took over,
it is a priority with CMS and all of the clinics because their main focus is transplant and going home. Yeah, and that's what they've been pushing for the past several years, and will continue to push for.
That's true. Yeah, one thing that we had heard, I forget where, about that is doing more at-home dialysis will alleviate crowding in the dialysis centers themselves, which could allow for more flexibility for patients. Because I know if you're doing like an 8 a.m. to 12 p.m. shift, and that's the one that you're locked into, and then every other shift that the dialysis center is taken, you can't switch to, I'm making it up, but 4 p.m. to 8 p.m. If all those beds are already taken. And so they do want to just provide more flexibility. And we've spoken with a lot of members who they look at transportation and physical access to care as a major issue. And they view doing dialysis at home as sort of one way to alleviate that. And, we spoke with, I'm going to remember it in a minute, Congresswoman from Iowa, and she talked a lot about rural health and how in her district, there are dialysis clinics, but it's not as easy for people to get to them as it might be in other congressional districts. And so, working with the dialysis companies to provide dialysis for folks at home more often is something that a lot of people are interested in.
I wish I could agree with you, Ben, that it's because of overcrowding in the clinics. As you know, I'm an in-center patient, 16 years. The main reason they want people to go home and or get a transplant is to save money. Statistically, transplant and home patients do better than in-center patients or have fewer hospitalizations and other costs related to their health. Yeah. That's the main reason. They don't give a damn if we have a chair, we don't have a chair, and can switch our shifts. It sounds nice to say, but they're just not that altruistic. I'm sorry.
No, I'm not saying that was the dialysis company's position. I can't remember if we heard that from somebody at CMS or where, but somebody was saying that one of the benefits of doing at-home dialysis is it puts less strain on the overall network together. But yes, people in general, people who dialyze at home end up having less health problems than
statistically.
Statistically, yes.
Yeah.
So that is also a big reason they are pushing at-home dialysis. But there's lots of ambassadors who have told me that they're afraid that there might be too much of a push for at-home and people might not be ready. And then if people are not ready and they have a problem with it at home and it messes up and they go back in center, then they're never going to do at-home again. So while at-home could be great for a lot of people, we have to make sure that it is provided to folks when they are ready for it, as opposed to, even though it might be the best outcome for them, if someone's not ready to do dialysis at home by themselves, then they're just not going to be ready. And sometimes it might just take folks longer to get to that point than maybe others would like, but we just want to make sure everyone's prepared for it.
And part of that executive order that he signed also dealt with organ allocation, accepting the organs, and looking at that whole delivery system all around as well. That was a component of that legislation as well, to move forward, I think, and they worked on that. And it was Alex Azar's dad that had the kidney problem, and that's why he was so committed to that, because of his father.
Yeah. And actually, I've mentioned it before, but Mark Meadows, who was President Trump's last chief of staff, he told us when we had an in-district meeting that his mom was a transplant nurse in North Carolina. And so he grew up around, thanks, Devin. He grew up around kidney disease. And so from a young age, he learned a lot about kidney stuff. And so, I always say this also, but he's a perfect example of why we work with every member of Congress. Party does not matter to us in the least bit. And why having those relationships with members and doing those meetings can really pay dividends in the end. Because when we met with him, I forget the ambassador, but she's the one who lives in Asheville. And he just happened to be her member, and she had a great application for the fly-in, so we accepted her. We had the meeting, and then we found out that this member of Congress, his mother was a transplant nurse, and then this member of Congress just happened to end up being a presidential chief of staff. So that's why it's always important to do the meetings with your elected officials, regardless of what level they are and regardless of what their political party is. All right, so it is 4 o'clock. So I'll see if I'll end the recording here. I'll give folks a chance to sign off if they like, but I am more than happy to continue speaking to everyone. So thanks to everyone for taking the time to join us today. And next month's Zoom, it's going to be, I believe, the 29th after Thanksgiving. Senator Albers from Georgia is going to be the special guest. And he passed the Living Donor Protection Act in Georgia, which was huge for us because he's a Republican and Georgia is a Republican state. So having such a strong Republican backing for LDPA on a state level is important. So we're going to talk to him about, why he supported the legislation and why advocacy is important.
What was his name, Ben?
Senator Albers in Georgia. So I hope to see everyone next month, and thanks.
Thank you.